So as I begin, no disclosures to report regarding the financial arrangements related to the contents of this activity, which is always an important thing to disclose. Yeah, so I think today is sort of one of our core talks that we've done and kind of repeated every cycle, which is an overview of our FDA-approved treatments for opioid use disorder. So the goal today will not necessarily be a deep dive, but just an introduction of what the treatments are, and we'll go from there. And my job and my goal will be to make sure that we are, coming to an end by about 30 after the hour, so we can transition to hearing more from New Mexico Health. Yeah, so I think for the next 25 minutes or so, we're just going to become familiar with our three FDA-approved medications for the treatment of opioid use disorder and kind of really start to get into how do you choose between one or the other. This is a question that comes up a lot. I know we got this from our trainees a lot about like, well, how do you pick between them? So we'll kind of start to think about that and in the process starting to get familiar working with a patient who may be on medications for opioid use disorder. And those of you who have seen this presentation, right, I know that I think, we always begin with this idea that still in the year 2022, we often think about detoxification or medically supervised withdrawal, right, as the treatment. But it is not, right? Because it's simply, when it comes to opioid use disorder, it simply does not work. In fact, what we know is detoxification alone does not improve any long-term outcomes for individuals with opioid use disorder. And that's sort of what this quote from Dr. Walter Ling that I really like refers to. Detoxification from heroin is good for many things, but staying off heroin is not one of them, right? It doesn't improve outcomes. Yet it's sort of in many ways, sort of in our Western world in the United States, that's kind of been the traditional model, the drug-free approach, the detox alone approach. And it may in fact work for a small subgroup. The problem is that right now we don't know who the individuals in that small subgroup may be. So it's very difficult to predict who just, might be able to go through a supervised withdrawal and never turn to other opioids again. We think these are individuals who are highly motivated, in general have stable psychosocial circumstances, but there is really no great data to guide us. Otherwise, without ongoing medications or maintenance treatment, a majority of patients who have been detoxified relapse or return to using other opioids, and very quickly, within the first 1 to 2 months. And as we know, use comes with lots of consequences, including the risk of overdose. So this is, something to really think about. This is a classic old study published in the Lancet way back in 2003 when buprenorphine was just sort of getting approved and coming online here in the United States. And what this study did is they took individuals, everyone had opioid use disorder, they got randomized. So half the people were withdrawn or detoxified with the help of buprenorphine. And the other group was maintained over about a 1-year period. And you can see that the group that was maintained on buprenorphine, even at 1 year, the treatment retention was quite high, right? Approaching 70% plus, versus look what happened to the group that was simply detoxified, right? Within 2 months, every single person had dropped out of treatment. And if you look at the other big outcome, there were 4 mortalities in the group that had been detoxified. They were tracked for a year and 4 people died, versus there were no mortalities in the group that was maintained. So that's a pretty significant difference emerging between the two groups. So I think that for me really captures the role of medications when it comes to opioid use disorders, right? Different substances are different. If I was talking about methamphetamine, for example, I would probably put the medications secondary. What's most effective right now, at least, are non-medication based approaches for someone who may have stimulant use disorder, methamphetamine type, things like contingency management or community reinforcement approach. But when it comes to opioids, I would argue that medications, our FDA-approved medications, really play a central role in treatment. I start with some of the outcomes for methadone, simply because methadone's been around the longest, and so has been evaluated rigorously the most, right? It's been around for over 5 decades at this point. So you can see that significant reductions in heroin use. 50%, depending on which study you look at, this number may go up to even 70 or 80%. Reductions in HIV transmission, significantly, right? Fourfold. Increases in employment, reductions in criminal activity and incarceration, fewer high-risk behaviors, more child support payment, more likely to remain in treatment, more Hep C treatment adherence, cost-effective, and mortality is reduced. And I'll get into that here, I think, in the next slide or so, a little bit more detail. And this is a slide showing that when people are maintained using methadone, there are these improvements in the number of high-risk behaviors, right? This is an old study. I largely included this because I think it's kind of fun to look at these old studies, right? And because UNM was one of the sites for this study. So one of these 6 sites is Albuquerque. Um, and what you find is that, when these are all individuals with opioid use disorder, and these are looking at crime days per year, with all of them coming significantly down once they're placed on maintenance treatment with methadone. And this is an off-sided study because this often comes up, right, where when someone's starting to open an opioid treatment program, you might run into community resistance. That is the crime gonna go up? And not if you dispassionately look at the data. I think that would kind of point away from that. Some other thoughts. Medications can be part of more comprehensive treatment, right? And when we stabilize someone on a medication, that's when we can start doing all those other important things like therapy or counseling, case management, healthcare, right? All of those things that then provide wraparound support to the individual allow us to work on healing underlying things like PTSD, right? Like improving some of the social determinants of health, treating underlying medical illnesses, helping create more positive social networks, coping skills, relapse prevention skills. So I think the medications allow patients to stay in treatment. They clearly seem to save lives, reduce illicit opioid use, and then we can do all of these wonderful things to hopefully help the individuals. So with that little bit of background, and I think we're right on time, gonna just briefly highlight our 3 FDA-approved medications, starting with methadone, which I already kind of started, right? It's been around the longest. I think some of the earliest studies I have seen were carried out in the 60s by Marie Niswander and Vincent Dole. And some of the data is quite phenomenal. I was talking about this with one of our trainees at ASAP last week, where one of the first trials I've seen of methadone was done in New York City. And they took individuals with opioid use disorder who got randomized to either treatment as usual, which at that time was sort of attend 12-step meetings, work on your sobriety, and the other group got started on methadone. And it was a kind of a ongoing, like a prospective study, but within 2 years, the two groups had separated significantly in terms of incarceration, in terms of wounds and sepsis and cellulitis, and there was separation in terms of mortalities, right? And along with things like legal problems. So after 2 years, basically the study ended because the two groups were so different that everyone was in the treatment as usual group was given the opportunity to get onto methadone. That's how impressive some of the early data were. And that's really remained. Subsequent studies have really shown the role methadone can play in terms of helping someone with opioid use disorder. It is highly regulated. I think there is legislation, as many of you may know, that would change this. Some changes have already started happening from SAMHSA here with our state's opioid treatment authority, but there is even more legislation rather, that's currently being looked at. Right now, it is a Schedule II medication and highly regulated, right? People often use words like narcotic programs or methadone clinics. The appropriate sort of formal term is opioid treatment programs. So if I'm going to use methadone to help someone with opioid use disorder, I cannot prescribe it right now, right? It must be dispensed from a federally licensed and regulated opioid treatment program. It is a full mu agonist. So the higher the dose, the more effective the more it activates rather the mu opioid receptor. So technically there is no ceiling, and it does allow you to titrate up the dose until someone's withdrawals are well controlled. Right now, you do need at least 1 year of documented opioid disorder, opioid dependence, right? Before kind of, again, this is all changing, the parental consent, all of this sort of, I put an asterisk next to, because, very likely it's going to be a non-issue. But I think the take-home point is that it remains a highly regulated medication. So while very effective, there are some treatment barriers. It remains out of the medical mainstream. There is stigma of specialized clinics, like location of clinics. If you think about here in New Mexico, there are several in the Albuquerque metro, Santa Fe, Farmington, but as we start kind of going away to some of the rural parts of the state, um, it may be very hard to access the clinics. Like we have patients that are a UNM clinic who come from over 2 hours away. And because of some of the regulation, they might be coming in multiple times a week, right? So you can see how that can create a notable treatment barrier. Buprenorphine is our partial agonist. So if methadone is our agonist, buprenorphine, which I know this echo primarily focuses on, is our partial agonist. In other words, it still binds to and activates the mu opioid receptor, but only to a certain degree. Eventually, it hits a ceiling effect. And once that ceiling effect is achieved, someone can keep taking increasing amounts of buprenorphine without more significant activation of the mu opioid receptor. And I think one of the big implications of that is that it is significantly harder to overdose on buprenorphine compared to any other opioid, including methadone, right? Because of that ceiling effect, it's really difficult for someone, a healthy adult, to overdose on buprenorphine. And I think that adds to its safety profile. It took the DATA Act, or the Drug Abuse Treatment Act, by the Congress back in the year 2000 that made possible office-based prescribing of Schedule III opioids, which is what buprenorphine is. Buprenorphine is a Schedule III medication. So DATA allowed, at that point, it was physicians alone to prescribe it from their offices. And 2002, buprenorphine was approved as a Schedule III opioid. Initially, doctors were required. It was, again, only physicians. Then they had to do this 8-hour special training and obtain what was called an X number. Many of you may remember this, and there were patient limits. All of that is gone, right? Gradually, starting about a little over half a decade ago, the field started to open up. Legislation started kind of improving access, right? With an eye towards improving access, increasing kind of the breadth of who can prescribe buprenorphine. And now the data waiver is completely gone, right? That's the important thing. And so anyone who's a prescriber and who has a Schedule III prescribing ability can, and I would argue should, prescribe buprenorphine for the treatment of opioid use disorder, which I think is what makes a training like this important. Because if you're going to start doing it, it helps to kind of get the knowledge skills and also the ongoing telementoring, just so people can start getting more comfortable with it, right? At this point, DEA is pretty clear, right? That anyone, can prescribe buprenorphine, and they do require that 8 hours of training. They're pretty non-specific about what constitutes those 8 hours of training, but I do know that these echoes count towards that. So for those of you who may be wondering about it, these trainings do count towards it. Buprenorphine, again, is a partial agonist, available as films, tablets. There are many different formulations there, which I know we go into in a subsequent talk. They're injectable medications, two injectable formulations. There is an implant, which is no longer on the market because there was no market. No one was using it, right? So anyway, so kind of going forward, and I'm not going to go into the nitty-gritty of buprenorphine because we, in fact, have a talk. I know that's done through this echo, which gets into some of those. I think office-based treatment has some real benefits. It allows for that continuity of care for our patients. It allows for that private, confidential, and safe treatment be provided, right? You don't have to go to a special opioid treatment program. You don't have to go out of town, drive long distances multiple times a week. There is that continuity, and it can be better integrated within the overall healthcare of our patients. I think, to me, that's invaluable. I can see someone, right, like, and I think Dr. Jacobson is part of this echo, of course, and I think she may be on. But we can work together to make sure the patient's basic healthcare needs are met, their psychiatric needs are met, their primary care and Hep C treatment needs are met, and their opioid use disorder treatment needs are met. So I think that's the important thing. So it improves access, allows for continuity of care. It's about as effective as methadone at reducing opioid use. And also, it seems like in terms of reducing mortalities, we have that data now, but maybe slightly less treatment retention than methadone. And that's really what the Cochrane review showed, no significant differences in opioid use if you compare methadone and buprenorphine head to head. So that's buprenorphine. And our last treatment is naltrexone. That's our antagonist treatment, right? If methadone is our agonist, buprenorphine is our partial agonist, naltrexone is our antagonist or blocker, right? It comes as a daily oral pill as well as an intramuscular injection that is administered every 4 weeks. What we know is that while both are FDA approved, the daily oral pill is not effective for opioid use disorder. Treatment retention is very poor. So if I would, I would recommend that if you're going to use naltrexone to treat someone's opioid use disorder, really think about using the injection long-acting naltrexone. Recent studies have shown that for many patients, this can be as effective as buprenorphine, but it is a lot harder to initiate. You had to wait 7 to 10 days from the last opioid use for the first naltrexone injection and think about how difficult it would be for many of our patients. And I think this has been the big barrier, for our patients is this difficulty to initiate. It is very expensive, but thankfully in New Mexico, it is covered through Medicaid. So I think that's a major, I think, positive we have here in New Mexico for our patients. So how do we choose? I just kind of want to introduce some thoughts, right? Um, so I think for naltrexone, I'll start with that, our injectable antagonist treatment. In general, it's going to be patients, right, who are either highly motivated or there is a group of patients who are not interested in or cannot be on agonist maintenance treatment, right? So, for example, certain professions, healthcare professions, pilots, naltrexone may be the only choice for them. In my practice, the time when I use naltrexone the most has been the group of patients that did well on either methadone or buprenorphine. Their lives stabilized, they began tapering off, and we were supporting them with the taper process. And as the taper ended, they started getting a little bit anxious. What happens when I go off of this medication? I certainly don't want to go back. In that case, we switch them over to naltrexone as a safety net while they build up their coping mechanisms, relapse prevention skills, and when they're ready, they can simply discontinue the naltrexone injection. We've also had patients who've been abstinent, who've been in remission, but they come and say, I'm at a risk for relapse because my stress has gone up. Maybe I'm in a situation with more triggers like moving to an old neighborhood, worsening psychiatric problems. They don't want to go back on methadone or buprenorphine. We'll often initiate naltrexone. Just last week, I started naltrexone on a patient who's really cut down their use of opioids to where they're using just once or twice a week. And their tolerance has come down. They're highly motivated. They have a stable support system, and they feel confident that they won't have significant withdrawals. So we opted to start them on injectable naltrexone. This was last week at our clinic. What about patients with agonists such as methadone? So actually, patients who have a history of overdoses, particularly following detoxification, we should think about putting them on something like methadone or buprenorphine. Because at least in theory, with naltrexone, there is a higher risk of overdose when someone discontinues treatment, right? Because naltrexone is an antagonist. When someone's on it, their tolerance drops or even goes away. So if they stop using it, go back to using another opioid, at least in theory, there is a risk of overdose, which wouldn't be there with with buprenorphine or methadone. Patients with serious mental illness, disorganized home lives, for many times for these patients, methadone can be a good treatment option because it allows for that structure. So we have a group of patients at UNM ASAP, who didn't do well even with things like acting, but they come in for their opioid use disorder for methadone maintenance treatment. And when they come in, that's when we have one of our psychiatrists see them, get them their long-acting injectable antipsychotic, meet with case management, peer support, to again meet those needs. So the structure provided by methadone maintenance treatment can actually benefit some patients, right? There's also a group of patients I've certainly seen who are opiate free but never felt normal, and for them, kind of maintaining them on methadone or buprenorphine becomes a good idea. Patients with chronic pain who require chronic opioid treatment. Naltrexone, I would argue, is not going to be a great option for those patients. And pregnant individuals, where again, naltrexone really does not have the amount of data that methadone and buprenorphine have, right? So the way I think about it is that maybe this is the list for whom we should think about naltrexone, but for others, we're really deciding between methadone and buprenorphine. And when it comes to choosing between methadone and buprenorphine, I often think about it with, and I'm putting this slide up, right, as a reference, that buprenorphine and methadone have in general about equivalent outcomes. But buprenorphine is a lot safer in overdose. You don't have to worry about drug-drug interactions nearly to the same degree. You don't have to worry about QT prolongation nearly to the same degree. It's more convenient for the patients and there's more access. So all things being equal, I often think about buprenorphine as the first line, with methadone reserved for more treatment refractory cases. Of course, with all of this, patient choice matters. So I don't want to, I really want to highlight that we need to listen to our patients and make that choice in collaboration. We've got a couple of minutes left. So I think I just kind of really want to highlight this slide. How long do I stay in treatment? For as long as it benefits the patient, right? Remember that opioid use disorders and other substance use disorders are chronic conditions that require chronic or ongoing treatment. So what we should not be doing is pressuring our patients, even sort of subtly, that we want them to come off of this potentially life-saving medication, right? Because then studies have shown this, that when patients get that message, they start telling us they want to come off of the medication because they think that's what we want to hear. And then you can see how that cycle can progress. Someone can come off of a medication prematurely, and you wind up in a situation where the patient returns to illicit opioid use or worse, right? So generally, for as long as benefits outweigh the risks, we do want to keep them on it, right? And generally for as long as possible. I really recommend against administrative discharges unless it's something for which there is no alternative, because that does increase likelihood of overdose and death. So we really want to do everything we can to keep our patients in treatment. And lastly, I end with this possible role of integrated clinics, right? I mean, all the data would point towards if they can integrate case management, peer support, psychotherapy, psychiatric management, primary care, something Dr. Jacobson I know does a lot, Hep C treatment, we improve outcomes.